Is first we're going to do some brief introductions. Then we're going to host a public listening session. And the listening session is super important because it's going to basically inform how we support training and technical assistance around this grant opportunity. So it's an opportunity to kind of share some of the opportunities and challenges you all are facing as fire departments, doing co-response in the field or aspiring to do so. And then we're going to spend the last section of our meeting discussing the innovation grant RFQ and the application process. And as Vanessa said, this meeting is being recorded and will be made available for any of your colleagues or peers who wanted to attend who couldn't be here. We will make it available on the CROA website after this. So let me just first make some background introduction, to give some background and give some introductions of who's involved with the administration of this listening session and grant process. So many of you know about Senate Bill 5644, which actually passed during the 2022 legislative session. That established a formal partnership between the University of Washington School of Social Work and the Co-Responder Outreach Alliance, or CROA, for training, skill development, and evaluation purposes. During that 2022-2023 year, we conducted a comprehensive landscape analysis, which many of you were a part of, that really allowed us to kind of map the field of co-response programming across the state, as well as to identify training and well-being needs that are needed across the state in terms of the co-response workforce. We also were able in that year, in the last session actually, to get proviso dollars for that actually went to the healthcare authority, and those proviso dollars were to provide funding for fire-based co-response programs, and also to do some training work around fire and EMS, who formally are seeking more training in behavioral health. So that's what we're really here to focus on today, are those proviso dollars. The healthcare authority has been incredibly great partner in this work and has decided, because of the work that we did around 5644 and this formal partnership that we have between UW and CROA for co-response, to send the dollars to the University of Washington, and then we're going to be distributing the grants and providing the training and technical assistance support. The healthcare authority is on this call, so they may be chiming in at different moments with questions, and I'll ask them to pop in and introduce themselves in a minute. And then this is like forecasting the future, but potentially very important update also is that we've got House Bill 2245 that is actually running this session in the legislature, and that would also further provide training and technical assistance to co-response programs and to co-response teams across the state. So what we're really trying to do, but with the fire EMS proviso, is push out money for programs to provide services, and then relatedly provide an 8-hour training for fire and EMS personnel, like line staff. Okay, but then 2245 is different from that. And that, again, that's in process this session. And that would allow us to develop a training academy for all co-response programs across the state. And before we kind of dive into the listening session, which is the first part of the meeting, you've already met Vanessa. I also wanted to just introduce other members of our team, if maybe they could turn on their cameras briefly. So there's Kim Hendrickson. Kim, do you want to turn on your camera for a second?
Hi there. Yep, I'm here, former president of CROA, and really excited to be moving over to the UW to support your efforts, Jen, and making sure that this grant program runs successfully and can promote some of the great work that's already happening in the state. I see my role here as a part of this grant as really somebody that many of you already know, that can be easily accessible to ask questions about this grant opportunity, get help once the grants are underway, and really serve as the starting point for what we hope many years to come of being able to really promote and support the work that fire-based co-response is doing in Washington State. So glad to be a part of it. Thank you.
Great. And Kim, very excited to have you part of the team. And I know you're you're very, very committed to CROA, and they've got an awesome plan with a new board chair in place. So that's great news. I'd also just like Jen and Silja to just turn on their cameras if they're not on already. It's hard to see with so many squares. But Jen and Silva, you just want to just do a quick name and introduction of yourself. And they're providing administrative support for this grant project and for the training project.
Sure, I'll chime in. I'm Celia Sodal, and I'm really pleased to be able to support this work as the special projects lead, and look forward to working with Kim and Professor Stuber and Vanessa in providing support for this, and also for potentially some training development. So look forward to working with all of you.
Jen? She may not be on. I think she had to pick up a kid from the bus. But just know that Jen Catajo, she and I share the same first name. She's far cooler than I am, but she's often the person you're emailing when you might think you're emailing me, but she's my amazing administrative assistant. So that's Jen Catajo. Oh, Matt Gower, are you on the call? From the Healthcare Authority.
I am, but we use Teams, and so I had to remember where the mute button was. Um, good afternoon, everyone. My name is Matthew Gower. I'm the Crisis System Team Lead here at the Healthcare Authority, working on implementing the services and operational infrastructure around the implementation of 988. I'm glad to be here and partner with UW and CROA to get this program off the ground.
Great. And Matt, it goes without saying, whenever you want to chime in and ask anything, please feel free to do that. We're just really grateful for your partnership. Okay, so as we mentioned, this first part of our meeting is really designed to be a public listening session that will really help inform the grant opportunity and how we seek to provide training and technical assistance to you all during this grant process. And so I'm going to keep my eye on the time here because we, of course, want to give you also the background information that you need to apply for the grant opportunity if you're so inclined after everything you learned today. But I definitely want to try to get through some of these questions. And I know we seem like we're a large group, 65, but I mean, I really want to help you all feel at home here and just know that this is your opportunity to kind of say, really what's on your mind around how the system is currently, the opportunities and the challenges that are currently facing and doing this very important work that you all do. So here's the list of questions, and I'll try to move us through them as quickly as possible. And then Vanessa, would you mind keeping a job? People raise their hands with a large group like this, that would be super helpful. And then if you could kind of call on people and unmute people, that would be really helpful.
Will do. Thanks, Jen.
Okay, so here's a great warm-up question for you all. Can you all talk about some of the ways in which fire-based co-response programs that are currently operating in Washington State? We know from the mapping that we did of you all last year that there's about 20 to 25 of you across the state right now, maybe even more since last year. But how are you currently enhancing the crisis response system? Like, so what are some of the unique things that you all are able to do, and how do you fit in your local regions in terms of providing crisis services for people with behavioral health challenges?
And Jen, is it true that we're giving priority consideration to applicants that answer questions on this call?
Yeah, sure. We
true.
can say that. We can say that for the sake of this. Yeah. Yeah.
Maybe.
Yeah.
Jen, do you want these typed in, or do you actually want conversation?
I'd love conversation, Nicole, and I know that you love to spark conversation.
I love that. So the first question, of course, of one answer. So how do fire-based co-response programs enhance the crisis response system? The fact is we're already responding to the calls. Even with 988, there's so many calls that get kicked to fire, and so we're already working with people in their homes, and much of the time they are in crisis. And so we're already there. And if we're not there, maybe a police officer is there, and then they're calling us to come in and help them. And so I just believe we're already in the field, ready to go. We're already showing up on some of these calls. And so I think fire in the state of Washington, at least on the West Coast, we are the ones that are responding into people's homes when they're having this crisis. It's very rare that we're not a part of this call. And so I think that's what you meant. And then how we enhance it is many of us have these co-response teams that we can actively seek where to get them the best care besides making the only alternative the ER. Did I get it right? Just kidding.
We may come
Thanks,
back to
Nicole.
you, but I know we have other hands floating,
Yeah,
but that was a great
Jen,
way
before
to
we
break the ice. Thanks, Nicole.
before we call on Jake, I did see Anne's hand raised, so I want to give you the floor.
You're on
Anne,
mute,
you're
Anne.
muted. There we go.
Why don't we come back to Anne and go to Jake?
Sorry about that.
Well,
I'm
now
so-
that I
Oh, sorry. I'm working off two screens because for some reason my other screen isn't working. What I was just gonna, honestly, she said it better, but what Nicole said, and I, we've had some opportunities, to bypass the ER entirely, which has been wonderful, and get them straight into treatment and much more appropriate, especially, I'm sure a lot of you are in places where the waiting room situation is pretty dire, and, to have them, even if they're supposed to be being monitored, they unfortunately often aren't because of personnel issues and really long wait times in the ER. So to be able to take them directly to an appropriate facility has been huge. I also like that I think we're contributing because at least in ours, we have a firefighter that gets put into the BRU for 6-month periods, and they grow and learn so much in those 6 months. And then they take that back with just a much greater understanding of the issues and how people can be helped when they go back out to the engines and the ladders and whatnot, than they would have if they hadn't had the experience of being in a co-response situation. That's it.
Thanks, Anne. Jake?
Since I just recently discovered that funding may be tied to contributing here, I'm going to add on to what my colleagues both just mentioned on both fronts. First, I think, having it embedded in fire, since most, at least in our program, all of our folks have a 911 nexus, it creates a continuum of care from the initial crisis point when 911 is engaged through to the follow-up care and the warm handoff from fire and EMS resources into longer term behavioral health services and more focused behavioral health services. And then just to add on to what Anne said, we've seen tremendous value having these resources in-house for our firefighters and our EMS providers to be able to see, maybe to have a more global picture of some of the folks they're engaging with in the field. And I think it's led, subjectively, admittedly, it's led to probably more compassionate care from a lot of our fire service folks because they do have a better global understanding of some of the challenges that these folks are meeting or are experiencing, rather than maybe just their one-off 3 a.m. meets with these folks when they can be at their most challenging to assist. So I think it's been really beneficial on both sides for our community and for our organization in helping people meet their needs more effectively.
Thanks, Jake. Brian?
Can you hear me?
We can.
Okay. I just wanted to say something briefly that probably everybody's thinking is we're in a unique position as first responders in general, both police and fire, when it comes to, we're kind of an underused resource. We respond to these calls on a 911 through dispatch, but that is an introduction point. When it comes to SUD and behavioral health, we have an opportunity to help people right then. And furthermore, we can refer at that point. And that's not really how EMS is set up. We respond to a 911 call and we go back to bed when we're finished. And nobody knows about a lot of those patients. So this is really important.
Thanks, Brian. I think Kelly next.
Obviously, everything that everybody has said, I find very valuable and true. The one thing I haven't heard said yet is a lot of our co-response teams provide some form of follow-up care. And that follow-up care is for those who are service ineligible or where the gaps currently exist in our systems, and they're providing comprehensive care to advocate and fight for those who are not being served by other community providers.
Thank you so much, Kelly. Appreciate that. I think Brett is next.
I think, speaking from a remote rural corner of the Pacific Northwest, where there's, pretty much a resources desert when it comes to social. What we've seen is the impact, where is really kind of in the follow-up and recidivism reduction, where, typically our community is using 911 as their PCP. So we've seen the CARES unit really be impactful with intervening earlier in some life challenges and getting them the right referral, which is positively impacting the availability of our limited resources. So I know that's kind of a long-winded answer, but I also have an observation. The question list, it's become obvious to me that there isn't one that's all for CARES, and so I think one of the questions, or one of the things that I hope to see is some recognition of it's, the CARES program that we copied in Paulsbo is actually different than what we actually implementing here. We used it as a primer, but we do things they don't do, and vice versa. Many of you do other things that we don't do, or maybe haven't gotten to yet. The more I look around at other CARES programs, I think that's one of the secret sauces. I hope that is understood. Is there isn't a there are certainly some themes and common challenges of CARES and services, but there isn't one all for all communities. Thank you.
Thank you so much, Brett.
Okay, so let's take a couple more, and then it actually would be super helpful if folks could put next to their name what fire department they're from, just so that we don't have to go through all the introductions. That would take way too long, but it'd be really nice when people are speaking if we know exactly where you're speaking from. But let's take a couple more before we move on to the next question.
Alex, and then we'll go to Todd.
Yeah, one thing that's been very interesting is it engages CARES and the fire department with the larger social services ecosystem. And that's been very helpful to learn opportunities and realize how many resources that we're just simply unaware of. And it just makes us better community partners. I think that's one of the most fascinating parts of what we're doing right now.
Thanks, Alex. Todd?
Yeah, I think that's a good point there is just finding out what your resources are in your area. We had the same issues. We didn't know what we didn't know. Our crews, the engines and the medic units respond on all the crisis calls, but then they do a referral to our CARES person who, after a warm handoff, we go and we meet with the people and we try and find them the services that they need. Again, really looking for the folks who are just falling through the cracks that don't really fit in any other categories. And I think we've made a pretty good impact in the past year and a half that we've been active. And we just see a lot more opportunities in order to make things better. So
that's great. Okay, so now let's turn to folks who maybe are on this call because they don't have an existing co-response program, but they might want to learn more and might want to start one up. Can you all speak to, for those who don't have a program, can you all speak to what are some of the barriers to starting up a fire-based co-response program? And by the way, if you didn't get to speak to a question and you want to speak to it, but we were just going to move on in terms of questions, if you could put your response in the chat, that would be super helpful, just so that we make sure we capture all perspectives But for those who want to answer the second question, who don't have a co-response program, what are some of the barriers to starting them up?
Money.
Hi, Jennifer.
Ned?
Yeah, I'm here. Are there any hands? I don't see any.
There
Oh,
are.
yeah.
Ned?
I see. Yeah. Did
Oh.
you say?
Yes,
Yeah.
there you
So,
go.
Ned Vanderpool with the Marysville Fire District, and I think for us, it's probably similar to many. It's the cost and just the workload. We don't really have the staff in place to take on implementing a new project, and with the unknowns that we have associated with it. So I think those are the big items for us. With what would it cost us financially, and in terms of personnel time as well.
Thanks. Chief, you're next. Is it Chief Fawcett?
Yeah, there we go. Chief
Great.
Fawcett here, South Kitsap Fire, and it's for us. It was the funding, or is funding. We were able to make part of it work this year, but when grants are only available for 1 year at a time, all of our money is generated by tax revenue, and that's typically for emergency medical services, and that's already been committed. Most of that has already been committed to our paramedics and EMTs, fire engines, ambulances, all that. So trying to make that money work and figure out alternative revenues. Money seems to be out there, but it's taken a lot of work just to try and get that funneled into us. So that's our experience.
Thanks, Chief. Martin?
Yeah, thank you, Vanessa. So my name's Martin Sanchez. I work for Greater Health Now, and we're currently working with 9 fire departments in the Greater Columbia region, which is Central and Eastern Washington. For our region, funding, one, that's the main thing. Everybody mentioned that already, but funding seems to be the main reason. The other is finding those mental health professionals and keeping them employed, since funding might be a 1 year, 2 year, and then what happens given that just behavioral health providers overall are in high demand for our region. Those seem to be kind of the most important aspects of not having a co-response team.
Great. It seems like we're getting some familiar responses to that question. So let's go on to the next one. So for those of you who are already running a co-response program out of a fire department, what are some of the barriers you have to sustaining those programs and expanding on them?
Nicole?
This one's my favorite. Of course, just like what you just said before, everything in the fire department is about the funding. And when a lot of our money goes to operations, the EMS side of it and the fire side of it, the CRP program is not something currently the fire department has a great reimbursement for. Like, we can't bill, like if we take someone to the hospital, that's a medical bill. There's a billing mechanism. For CRP work, there's just, or MIH work, there's just not. And so currently my program runs on grants. So you get to be really creative about finding grants or contracts. Like they said just a little bit ago, they're often only 1 year. So you're placing staffing there, hoping that you have a space for them to go back if the grant runs out and you don't get pre-approved or get approved again. And to run a program as a program lead right now, my heart aches knowing that maybe next year I can't get a grant and I'll have to let go of everybody or put them back online. That is probably the biggest thing that I stay awake at night, trying to figure out how my program will survive next year. Like, literally. And it's often like I tell people I beg for money. I beg my commissioners to give us money. I beg, and I don't beg. I write really great things to say, please give us your dollars. So that is our biggest gap in fire, I think, with these programs.
Thanks, Nicole. Brian and then Mike.
Hi, so I think that there's several. One is personnel. You need to have the right people, and also people that are people are thinking about program development, making sure that your management at a management level, that they're on board with this so that they can push it to, the city or the county or whatever. And you really need like a foundation of data. Every area that has a co-response program is going to be different. The needs of the community are going to be different, demographics and everything. So you have to figure out what it is that's the biggest benefit to your community, and then collect the data regarding that, and then show it to everyone, show it to all the grantors, show it to your city manager, show it to your fire chief, and reach out to other community members, hospitals, other agencies that can help you promote that.
Thanks, Brian. Mike?
I think just in general, with this space being relatively new and innovative, there seems to be a lot more interest in startup than there is continuation. Folks want to start it up, and we're still working through that proof of concept and really capturing the effectiveness. And no one has really shifted to offering a lot in the way of resources for continuation of the programs.
Great. Well, so let's shift on, and again, if you have additional thoughts and feedback on that question, if you could please add it to the chat. Let's move on to the fourth question, which are, and I've certainly heard a lot of this with the landscape analysis we did last year, but if you could speak more generally now to barriers to collaborating within the crisis response system. So that is like, or maybe not just even framing it as just barriers, like, so let's talk about like, how is it going in terms of being part of the broader crisis response system, meaning, the crisis call lines, the 988 line, the mobile crisis teams, the DCRs. How are you all seeing yourself as fitting in? How's the coordination? What would you wish? What do you wish could be better? This is your chance to kind of voice that. Big question.
Brian, is your hand up? Is that new, or was it from the previous question? All right, we'll go to Anne and then Nicole.
I think where I struggle a little right now, or where we're struggling a little, is with the mobile crisis teams, and how they integrate and how they operate so differently from, say, like our CARES team. So we have our behavioral response unit, and our provider, our mental health provider, comes from the same company that the mobile crisis teams come from. She's contracted to be with us. But the mobile crisis teams, they clearly have a lot of pressure on them to not keep cases open very long. So there's often a very short window that the cases are open, sometimes just a few days. And where our CARES team will keep the case open sort of as long as it's productive to keep the case open and the need is there. And I think there's just such a huge difference between those two things. I would love to see the mobile crisis teams keep cases open longer. I think that's the biggest barrier we're having right now.
Thanks, Dan. Nicole?
I think our biggest barrier is that, I'm just going to say, it's called relationship building. So I've been in this office for almost 5 years, and there are still, since we do, just like Anne said, a lot of other places will close their cases, or they don't realize what's happening in the home and the 911 use. So we often spend multiple interactions with PCPs, social workers, care coordinators, case managers, saying, please listen to what we have. I have documents of this person's lifestyle at home, and he keeps calling 911, or she keeps calling 911, and we're begging the doctors to listen to us because they're not used to having an EMT firefighter reach out to them, or a paramedic. And so in one case, we have a gentleman calling us 3 times a day. And we've talked to cardiologists, doctors, and they wouldn't increase his anti-anxiety medicine. And we actually had to finally get them all together after months and say, sir, the amount you're giving him is for a small child. This is an adult male. And they finally listened. We improved the medication, and the gentleman doesn't call us anymore. And so our interaction's very important, but they're not used to seeing us as anything more than an ambulance person or someone who puts out a fire. So I think relationships are important. And when I say that, even DCRs, took me a couple of years to get a really good relationship with our DCRs. They are more apt to come out to a call now for me than they are the police officers, because I say, I'm a medic, I'm a provider, I see the medical side. Here's what I've got for you. Here's all my documentation. Here's pictures. We are a valuable resource in the field. Even ER docs, they don't know what it's like when they send a person home. I go home and hold that person's hand and call the next person with them so they can get the medication. Like, we are literally the people, our clients are like our family, and no doctor's doing that. Many social workers, God bless them, they're not going into the person's home as much as we are. We're there at that moment. And so I believe this whole state gets to take these co-response teams and advertise this like crazy and say, this is what we do. I can help you. Like, this gets to become much bigger than this. So that's our barriers. They just don't know what we do. That's all.
I just want to point out Brett's comment about be nice if grants somehow encourage fire and crisis team coordination. Well, guess what? We have that grant opportunity here today. It's exciting.
Thanks, Jen. Rebecca, and then Brian.
I think I would add, kind of like Nicole was saying, I'd add to that list, the emergency department to the crisis response system. We work a lot with emergency department social workers, and the outcome is so dependent on if we have a relationship with them or not, or if it's like the night social worker or per diem social worker. So it's really, really frustrating, because it shouldn't be dependent on like that individual. There should be systems in place where we're taking better care of people and not sending them home to a bad situation. And I would say in King County, we're able to work with the mobile crisis teams in general, but they don't do any follow-up. So that's challenging. They're often being called up for people who are living outside, and doing no follow-up is not super helpful. So they're fine in the moment. I just don't know, like, really the efficacy of the program long-term. And DCRs, we in King County, I think it is different in other counties, but we can't really call a DCR out to see our clients. It takes weeks and weeks for them to come out. So we end up taking people to the hospital so that the DCR will have to come out more quickly. So it would be so much more efficient if we didn't have to do that, and we could keep them out of the ED and call the DCR ourselves and have a quick response.
I just wanted to, I think Captain Picknell kind of hit the nail on the head with networking and some form of advertisement. EMS, we're still, still relatively new in how things work. But, and for a long time, we focused on fire prevention. So we really need a hand in promoting these programs again, like it was done back with fire prevention, having someone to renew all of this and say, wait a minute, we also add this, we add this other, these other services to it. And so having that kind of a top-down approach, and where somebody up much higher, like Nixon did for fire, we need somebody to do that for EMS and behavioral health and SUD.
Jen, could I pose a question before we move on to the next one?
Of course, Kim.
Thank you. Is there anybody on this call that can work in collaboration with their local mobile crisis team? And by that, I mean the mobile crisis team might call them if they're the more appropriate response. And there's a fluid relationship so that your co-response team or your fire department can call the mobile crisis team for something other than a DCR evaluation. So just looking for anybody on this call that's figured out a way to work with the mobile crisis team in real time to do cross referrals and collaboration. Thanks.
So, sorry, I'm jumping in. The one way that we have just very recently started working with our mobile crisis team is by providing them medical clearance. So if they identify a patient, this just like, for instance, happened last week at one of our larger shelters. They identified a client who, needed to go directly to a behavioral or mental health treatment center and did not want to take them to the ER because we've got these like 10-hour waits. So they called out our behavioral response team. We're now carrying an ISTAT, and we have made a protocol agreement between some of the facilities and our medical director of a checklist of like, what lab values they need to have, no alcohol on board. We also carry a breathalyzer. And then we can do the medical clearance for them right there on scene, and they can go directly to the facility. So that's the one way that now our MCAT teams are actually contacting us.
But how to take advice from our brother that has no one?
Do you want me to call on folks to continue speaking on this one?
All right, Vanessa, go ahead.
Okay, Sam.
Yeah, this is Sam Lewis with Clark College Fire Rescue. I think our biggest one is, working with our mobile crisis team. We have a pretty good relationship. We actually have them contracted both with our mobile crisis, kind of our co-response unit that really coordinates with all our follow-up cares units. So we sort of have them together. So we have them sort of embedded in our program already. So we're really, doing trainings with them. We're having meetings with them constantly, and we're able to use our mental health professional on that team to really kind of navigate through some of those more sometimes confusing ways of getting a DCR or getting other folks to help and so forth. So I think it's been really helpful to have that connection and that relationship and continue to build on that. Because we do use them. We use them sometimes for mental health follow-up when we're not using them for our CARES program. And then there's a lot of kind of they're able to kind of understand what we do and so forth.
Great, thanks, Sam. And in the chat, Tacoma Fire Department does, and Diane in Bellevue also.
Let's take one more and then I'll go on to the next question.
Cassie?
Thank you. So I'm with Tacoma Fire Department, and I was just going to say we have a really unique opportunity because we have DCRs that are embedded from the crisis team within law enforcement, and then we have the HOPE team that's embedded with the fire department providing alternative response. And so we've established a system where first responders, fire, and law enforcement are able to send paper referrals to both the DCR and our team. And so we're able to collaborate to determine if the person or the individual is requiring an evaluation. And then the DCR would take it, and we will take all other levels of care. And so there's a lot of coordination between the two parties. Additionally, we have direct radio access between the DCRs and our team. And so if we're on scene and someone is escalated or is requiring a higher level of care, or is perhaps refusing services, but they don't appear to be within cognitive or volitional control, we're able to escalate it directly to the DCR and have them come, and we can all coordinate on scene while they then do the evaluation. And if an invol is necessary, we then have transportation there to also take the individual to the emergency department. So we felt really grateful for our ability to coordinate with the DCRs that are also embedded with law enforcement.
Great. So it sounds like it's working quite differently and to varying degrees across the state. Not unexpected. Let's go on to the next question. Has any department on this call become a rapid response team as defined in 11 House gross substitute, 1134 from last year? Why or why not? So, or has anyone gotten through and gotten that designation as of yet? And kind of, can you speak a little bit to your experiences around that? Okay, let's move on to the next question. Do we have a hand?
Jen, we have Alicia.
Oh, okay, cool. Great, Alicia. Hi.
Hi, Alicia Morales. I'm the counterpart to Cassie at the Tacoma Fire Department. I
from my standpoint, I didn't know that that designation was available yet. I thought that there was the mobile rapid response crisis team and then the community-based crisis team, and I wasn't aware that either of those were active yet. Our team is falling in line with, pretty closely in line with the timeframes that are requested in terms of receiving a call and then responding within, I think it's 20 or 30 minutes for an urban area. So we are doing that. I just wasn't aware that the designations were up and available.
So they're probably not, and I'm going to have Matt speak to that at the end of this. Matt, so I'm preparing you now, Matt. So we were just more curious as to like if people are thinking about that opportunity, and you know, so it sounds like there's at least one department on here who is thinking about that, and is tracking it closely. And I'd be great to have Matt kind of speak a little bit more to that in a minute. So a couple of the other things we're going to be looking at with this RFQ is really around considerations around becoming a behavioral health agency to be able to bill for co-response services, and administering medications for opioid use disorder in the field. And Kim's going to talk more about this in a minute, related to some of the areas of innovation. But I think before we jump into the opportunity, we'd like to hear about some of your experiences with a couple of these areas of innovation. Specifically, are you billing for services as a BHA or trying to do that? And are you administering medications for opioid use disorder in the field?
Brian?
First of all, the behavioral health agency option, I didn't know. I don't think we really knew that was an option. So that's say it's a point of interest. As far as administering medications, like MAT services in the field, we're pretty excited to have our county health officer and medical program director locally have signed off on a county operating procedure for us to administer buprenorphine if indicated. And we have a very close relationship with our REAL teams and SUDP services and other options for referring patients to us, or to, of course, to see them on a 911 call and have a medic unit request us to evaluate a patient or stay with a patient, evaluate them for administering buprenorphine. And hopefully, we know that's not the end all be all, but it is another tool in the box.
Thanks, Brian. Nicole?
Yeah, I was gonna, the behavioral health agency, we recently researched it, and it sounds like it's going to take us quite a bit of personnel hours to figure that out. From what I understand, I actually have some light duty captains that are helping me research that. And if I didn't have those light duty captains, my CRPs are in the field working with thousands of clients. So it takes a whole individual to research that. So I think sometimes when we talk about these co-response teams, the same reason some agencies don't have them is it takes a bit of work to set it up. So same with the behavioral health agency, we've got some work to do, and it's going to take us a while to figure that out. As well as the administration of medication, though, we are kind of following the coattails of North Snohomish County, Matt Hickman and Dr. Corsa. It sounds like there's protocols that have been sent to the state. If that's approved, then we will, Dr. K, our doctor, will then hopefully approve that our teams, that's my next endeavor right there. As long as it's passed through the state, and we all know that could take a little bit with protocol changes. That's all I got on that. Thanks.
Cool. There's some agencies in the chat that are also doing that as well, or exploring it. Brian?
I think Anne might have been before me there.
Anne?
So we actually are, as of Wednesday next week, we're going live with our buprenorphine, Suboxone program. So got all the sign off, got all the training that we needed to do, and it will be we will administer, if their COW score is appropriate, and then our paramedic of our behavioral response unit will administer the Suboxone, and then our mental health provider, our professional, will get them a treatment bed, and this is all providing they agree to all of this. And then they will go into treatment, and then our cares team will be doing the 30-day, follow-up, and the EMS office and the cares team will be keeping track of that patient, do a 30-day follow-up to see where they're at, and make sure they get some of those wraparound services. So that's the plan. Supposedly Wednesday, we just installed the lockbox in the VRU. So hopefully that'll happen on Wednesday.
And as someone that's been through the process, were there any obstacles other than, obvious things that you might be able to share with us? Was it relatively easy?
So it could have been, I think, easier. We partnered with Washington State University, and so the whole IRB process, because we're doing it like as a trial, the IRB process has been absurdly time consuming. Honestly, we thought this was going to go live almost a year ago, and we are way, way, way further behind than, we would have been. We sort of had to create our own training program. And it's about an 8-hour training. I don't think it needs to be quite that extensive, but we wanted to err on the side of caution. So it's a pretty rigorous training program and test that we're putting our firefighter provider through, and also our mental health provider went through it as well. But other than, I don't think it needs to be as difficult as it is. And certainly if the state approved the drug, then it would be much more, we could have done this very quickly. We already had the CARES and the BRU in place, so that part made it quite simple.
We'll go to Brian, Dawn, and then Ashley, but I do want to point to Nicole's question in the chat. So if anyone could address that as well. Let's see here. Does the BHA need to have a mental health supervision? Brian?
Just a quick note for people in larger areas. I have read that I live in kind of a smaller area out here. We have one hospital, so they don't really have much choice. But if you're able to find a hospital that will maybe align with your goals and treatment plans, as an overdose receiving facility or something, it may be easier to have a medical program director or someone in that area go along more easily with this.
Thanks, Brian. Dawn, and then Ashley. We'll come back to Dawn. How about you, Ashley?
Yeah, so the way things work, so I'm up in Whatcom County in Bellingham, and our co-response is Bellingham Fire as well as the county fire. But speaking of Bellingham Fire specifically, we partner as the health department. We're a behavioral health agency and provide the social work. We have like 3 or 4 licensed clinical social workers who provide the supervision under the BHA. And then Bellingham Fire, I know, is interested in providing BUP in the field. But as a holdover, we have an ARNP on staff through the health department who is able to bridge buprenorphine until someone's able to get in to see a regular provider.
Thanks, Ashley. Dawn? Might have lost Dawn. Back to you, Jen.
Great. Well, so thank you so much for participating in that. Before we transition over to a description of the grant opportunity, and you'll see, I think, pretty clearly why we asked the questions that we did. I just wanted to see if Matt over at HCA has any follow-up questions or comments he wants to make based on anything that was said or heard. or said or typed.
I was having a hard time keeping up with the chat. You guys are much faster typers than I am. I do want to speak to the 1134 endorsement. We are set to publish the endorsement standards in April. We'll also be launching a grant program around that time for teams that need to get whatever to meet the endorsement. So vehicles, staff, whatever. So those will be, like I said, launching in April. We are hoping to kind of socialize the standards here in the next month or two. I was actually hoping to do that by now, but there's some delays as always in government work. So I just want to let you guys know. So if you were part of the listening sessions we had last fall sometime, time is blurred together for me. We'll be reaching out to you directly, and then we'll also work with Jen to make sure that we have a good representation there. And then the only real question I have is any department utilizing peers, so like certified peer counselors or people with lived experience on any of your teams, or have you guys explored it?
Alicia?
Our team is going to be hiring a certified peer counselor. So we've been contacting the healthcare authority and speaking with staff there who've been very helpful about setting standards, and then also having the conversation of the crisis specific peer training that's available.
Okay. That's great to hear.
And Nicole?
We did have a peer, and she went up north to Matt Hickman. So Matt Hickman, I believe Christine is actually a peer, and we're currently using community health workers, which are also not certified social workers with any degrees, and they're fantastic. So I don't think you always have to have a social work degree to be able to be paired with a fire department personnel to be able to find resources. So totally viable options, and they're working amazingly well.
Great. Anything else, Matt, you want to make sure we capture?
No, I'm sure we'll be talking with a lot of you again, so I look forward to that, and I'll probably have better questions for you then.
Great. Okay.
Jen, before we move on,
yeah.
I'm so sorry. Dawn fell, dropped and came back, and she really is our go-to expert to talk about things like MOUD in the field. Dawn, are you back on to be able to speak to questions about the process to administer MOUD in the field? Phooey. Okay, we'll get her later.
Okay, Kim, you want to take it from here?
Oh, sure. Absolutely. All right. So we are so pleased to announce, thanks to Representative Dan Bernowski's efforts in the legislature and the healthcare authorities' interest in supporting this work, a brand new grant program coming through the University of Washington with the assistance of CROA to not only support and promote co-response teams in the fire service, but also to encourage innovation in departments that are running co-response teams as well. So to give an overview of what this grant program is trying to do, we're going to be awarding up to 8 fire departments, innovation grants for the delivery of co-response services. The purposes of these grants is to encourage the development of fire-based co-response program within the emergency response system, bringing together critical multidisciplinary approaches to address complex medical and behavioral health needs in the field. In addition to promoting innovation and supporting co-response, the purpose of this grant program is to pilot high-quality training for firefighters and EMS personnel to better prepare them to work with individuals struggling with behavioral health issues and unmet needs. So when I'm talking about this grant opportunity, if you keep in mind, it really has 2 major parts. We're looking to promote innovative co-response, but we're also looking to use departments that have been awarded funds to pilot trainings in different regions in the state to push out high-quality behavioral health training to firefighters, medics, EMTs. More about that in a second. In terms of who's eligible to apply for these grants, we really are looking for fire departments, public agencies to apply. We welcome applications from departments that have co-response programs, but we also welcome applications for departments that want to create a program that are in an area where a program doesn't currently exist. This is an innovation grant because we are, and I'm going to do questions right at the end. So if you guys would hold them, I'll be happy to get to them there. We're going to be giving priority to departments that are able to state and meet goals in 4 priority areas. And we've been talking about those areas during the listening session, and I'll spell them out here. We're looking to prioritize applicants that are interested in becoming a behavioral health agency and bill for behavioral health service. We've already gotten questions about how far along do you have to be? Are we looking to become a BHA within the grant period? We'll be flexible. We're looking to encourage departments that are looking to go in that direction without a clear sense of how long the entire process takes, and happy to delve into that during the Q&A session. We're looking to fund programs that are looking to start or expand their MAT programs, their MOUD programs, and doing induction of medications in the field. We're looking to fund programs that are interested in operating either a crisis response or a follow-up unit that is integrated into 988 or your local regional crisis call line. And finally, as I mentioned before, if it's a new program in an area with no existing co-response program, that would be an area of innovation we'd like to support as well. Priority will also be given to departments that can demonstrate the capacity to start or expand their program quickly. This is a very short time frame that we have to push out these grant funds and measure performance. So we're looking for departments that are able to move fast. We will give priority to departments that can demonstrate a capacity to braid multiple types of funding. As that previous conversation showed, folks running programs have to be highly creative with how they fund their programs. So definitely we'll be giving priority to departments that can show they know how to access their county 1/10 grants, BHASO funding, state grants, federal grants, et cetera. Finally, we're interested in giving priority to departments that are willing, in addition to training requirements, serve as a more informal learning site for other fire departments. If you're doing something innovative, is there somebody on staff that's willing to take a phone call to talk to another department about what that is? Do some ride-alongs and offer some assistance to other departments looking to follow in your footsteps. So when you're writing up your grant application, I'd strongly recommend that you keep these priority areas in mind, because that's what we'll be looking for when we're doing the ranking. We have tried to keep the reporting expectations minimal. Again, the point of these grants is to promote new projects and innovation and departments doing things that mostly have not been done before. We don't want to weigh you down with a lot of reporting requirements. However, the expectation is that a monthly, very short report will be issued explaining progress on the innovation goals. And we'll be looking for basic metrics about the fire department's behavioral health calls and co-response service. When we get into the application itself, I'll be able to show you the specific metrics that we're looking for. And hopefully applicants are already collecting this information to persuade their stakeholders to continue their programs. Departments will be awarded up to $350,000 over a 15-month period. After an initial startup reward, payments as pursuant to this grant will be performance-based, which is somebody that applies for and receives grants is really helpful because performance-based contracting is flexible funding. We want to encourage the creative use of the grant funds as long as it's generally related to the grants goals and your fire department's co-response program. If you wanted to use funding to pay for a vehicle, great. Outside billing, great. And admin, terrific. Equipment. Unlike many other grants for co-response programs, we are extremely flexible in what we will be able to fund. Again, as long as you can show us that what you're purchasing will enhance co-response and your innovation areas. So as I mentioned before, it'd be helpful to think of this grant opportunity in 2 big parts. The first part is the promotion of 4 innovation areas and funding a co-response program that's new or already exists. Now we'll switch over to the second part, which is looking to use these grant funds to push out high-quality behavioral health training to crews throughout the state. Our training expectations to awarded departments is that you will offer 2 regional trainings in 2025, training a minimum of 20 first responders and co-responders in a new behavioral health 8-hour curriculum that we'll be developing in 2024. In order to hold these regional trainings, the expectation is that awarded departments will identify 3 firefighters, EMTs, medics to serve as trainers for these 2 training sessions. The University of Washington will be doing training of trainers, providing curriculum, covering some of the costs involved in train the trainer and training activities. But it's really important to us that applicants understand that in return, so to speak, of these very flexible and I think really productive grants, the expectation is that you'll be an active part of a new training initiative that looks to push out 8-hour behavioral health training across the state to firefighters and EMTs. Okay, the process. A request for qualifications is being released today. When I'm done with my little slide presentation, I will show you where on the CROA website you can get that specific information. As I mentioned before, the turnaround time is tight. Funding applications are due on March 8th, and you'll know if you got an award by the end of March. We're going to be moving very quickly. There is an opportunity to ask questions about the RFQ after this call is over. We mentioned Jen Cataggio earlier in the call from the University of Washington. There's her email address. I'd encourage you to write it down. If you have questions about anything involving this application, please write to Jen. We'll take those questions. We'll post them on the CROA website along with answers. We need to receive questions by March 1st in order to post them and disseminate the information. Finally, the responses that come in as a result of this RFQ will be scored by a review committee. That review committee will consist of people from the University of Washington, at least 1 representative of a fire department with a co-response program, at least 1 medical director, and at least 1 person from the Department of Health. Okay, before I get to questions, if you bear with me for a second, I'm going to show you all where to look for the RFQ and the applications on the CROA website. So bear with me for just a second. I hope you've all been to the CROA website by now. If you haven't, it's a really good source of information about events that are happening, opportunities, training, how to become a member. Here we are at croawa.com. For information about this RFQ and the information, the application process, put your cursor over to the opportunities page. Once you're in opportunities, first thing listed will be these fire department grants. RFQ and application questions are available here. That will link you to a much longer explanation of things that we've gone over during this call. I mentioned before that if you looked at the application, you could see the specific metrics that we're looking for as a quarterly reporting requirement. They're listed out here. Peruse them at your leisure. I mentioned Jen Cataggio. Her email is here listed on the link from the CROA website. And then here's the application. We are not interested in you writing a 10-page essay about your hopes and dreams in the fire service. We kept this application very streamlined, very focused, in the hope that it wouldn't be an obstacle for departments to apply. It's a fill-in form. Most of the answers are a paragraph in length. Lots of yes and no questions. But the longest part of the essay, where we do hope you spend the most time, is talking about your goals specifically related to the innovation area and what the obstacles might be in achieving goals in that area. So when you're done filling this out, you simply hit the submit button. It automatically goes to Jen Cataggio and then to our review committee. And with that, we would welcome your questions.
I just wanted to mention real quick, Kim, as somebody who does own several behavioral health agencies throughout several now counties in Washington, you do actually have to list a licensed behavioral health specialist, whether it's a mental health professional or if you're getting licensed as SUD, you actually have to list a licensed clinician in that space on the application to be a behavioral health agency with Department of Health.
Thank you, Gabby. And something that we should have mentioned before, which your comment reminds me of. For those departments that are interested in applying for an innovation grant to become a BHA, we plan on working very closely with you and the Department of Health and hopefully the Healthcare Authority to put together a toolkit so you're not figuring this out alone. It's very important to us that the awarded department becomes a model for other departments. So we will definitely be working with you to make sure information like Gabby just expressed or has been expressed in the chat is readily available to you so you're not starting from scratch as a part of the BHA process.
And the funding is flexible such that if you needed to hire supervision or someone to support in billing, funding could be used that way.
Yeah, Jessica, question, please.
Can you hear me now? Will tribal organizations also be eligible in this grant?
Yeah, out by me, we don't have tribal run fire departments. Is there a tribal run department out in Colville?
Yeah, so we're actually based out of Nespelem, and then we also have a station in Inchelium. We are a fire, EMS, and rescue department. So we do it all. And
we would welcome your application. We would
Okay.
absolutely welcome.
I honestly don't think we're at the point where we are even competitive for this grant, but I do think that we can make the steps to get there. But it's fostering those relationships and finding, I mean, we are to fill our positions, let alone adding things to bring it full circle as we're in, I mean, a more rural area than I think people realize exists. And so it was great to listen and see where everybody's at, but I feel like we're in a totally different state.
Well, before you make a final decision, right? That fourth innovation area is really intended to get services started in places that they don't currently exist. So while 3 of the innovation area would require quite a bit of, I think, experience and time to become a BHA, to do the medications in the field, to integrate with 988, the fourth one doesn't. The fourth innovation area is if you're in a place that's underserved, can you start a program to start to address that need? So I would encourage anybody that's on this call that doesn't think they're quite up to this grant to just think about that fourth innovation area and starting a program to fill service gaps. I'm happy to talk about that after the call in addition. Great question. And by the way, the reason that we're being firm on asking public agencies to apply, and public would certainly include tribal agencies, we don't want to create yet another duplicate system that's not able to communicate within existing systems. So if we're asking for fire departments, tribal departments, if you're already operating within the emergency system, we have a better shot of integration than if we're looking to encourage programs that are operating outside of the emergency response system. So that's the logic behind that. Yeah, questions, Nicole?
I was just going to add to that. Anyone who is unfamiliar with doing grants, I had no clue when I started this job, and it is now my biggest endeavor. And you be creative, make it up, because if you can make it up in your head, you can do it. And don't be afraid. Apply for all of them. If you qualify in any way, like apply for them, because you'll be surprised of the amount of money that you could possibly get if you're just open to having a vision of what it could look like. So that was just basically, hey, I was there just 4 years ago, and now I'm like, nope, you can create everything you want. I promise you, everything you want. Apply for all grants anytime, always. Lots. I'm done.
Questions, Anne, about the grant or anything else?
Yeah, so thank you. This is an awesome opportunity, and I am very intimidated about doing a grant application, but I appreciate the fillable form.
I got you, Ann. I got you.
Okay, and the direction.
Make sure you use Grammarly. Just kidding. We're just joking.
Oh,
We don't care about any of that. We're
believe me,
joking.
I use Grammarly. I need it. Where else should I look for grants? I don't even know where to look for them. I think that's been problematic for me. Please tell me there's some big grant clearinghouse that I can find.
There's not, but I know you're a part of CROA, Anne. I know
Yeah.
that you're a member, and I would just encourage you and other members of CROA to continue to work with Vanessa, our managing director. If there's enough demand from members to do an entire quarterly meeting about ways to apply for grants or where grants are available, CROA was created to answer questions like that. So, I see at least 3 board members on this call. I think there's 4. They're hearing you say this. This is the beauty of the organization. It can help you either individually or through group meetings identify creative funding. But, to cut to the chase, the bad news is there is no clearinghouse. There's very little consistency. I think that thanks to the work of the HCA and the UW, we're starting perhaps to see the beginning of what I hope is many, many years of funding for fire-based co-response programs, but we're just at the beginning.
Okay. No, thank you. I appreciate it very much.
And remember, Matt Gower said that the healthcare authority is going to be pushing out grants to correspond with the announcement of certification requirements to become rapid response teams. That's a really exciting announcement.
Yeah.
Other questions about the grant? All right, just again, this is recorded, so if there was something that you want to hear again, it'll be on the CROA website shortly. Nicole, I love your encouragement to just get in there and try. We really worked so hard to make an application that was streamlined and simple and focused. We hope this is an enjoyable process and not an onerous one. We all know how busy you already are. Jessica, did you have another question?
I do have one more question. So right now there's a rural EMS training grant that's out from SAMHSA. And I think I'm saying that right. For the substance, all those letters. But if I know that's a training grant, if you were awarded that and your department's already going in to do the COD trainings and the mental health trainings to improve your response, how would that look if you were also awarded this grant? Because I know you can't commingle funds per se. Would there be anybody to guide you through that process?
So on our side, it's not going to be a problem, Jessica, because these are performance-based grants and you can use funds however you think is appropriate. On the other funder side, I can't speak to that. But one of the nice things about performance-based grants is that they're very, very flexible, and we're intending for these funds to be used by your department however you think best.
Okay. I appreciate that.
I think, all of us we know how complicated and how many barriers already exist. We don't want to create any more with this grant opportunity.
Thank you.
Jen, it looks like we've answered the questions. Is there anything else that you'd like to say?
Well, just that we haven't spoken very much about the training piece of this opportunity, and what I just wanted to say about that is that we're going to be working really closely with some fire EMS subject matter experts to develop the curricula this year. I've started to reach out to who those people are. But if that's an opportunity that really interests you, you'd love to develop curricula, and you want to be a part of that subject matter expert group, just let me know. I'll put my email in the chat as well. And then I would say that, we're going to end up here. So let's just say hypothetically we're successful and we get all 8 departments, and then you're all nominating 3 people to become trainers. And that means we're gonna have this awesome network of 24 people across the state who can then be subject matter experts and train future trainers and just basically holding that space around a deeper knowledge around behavioral health and crisis response. So that's a really cool opportunity for growth for people within your departments. And while it may seem a little bit like, depending on how your department's organized, maybe separate from the co-response program or the CARES program that you're running, I mean, I think we're really trying to seek a broader culture shift, also around the whole department, kind of increasing their education in this realm, because we know that our healthcare, our calls in response to the health needs can't really be separated cleanly from mental health needs. So we're really excited about that and hope you are too. And just wanted to say a bit more about that piece.
Yes, I think we'll turn it back over to you.
Thanks, Kim. Thanks, Jen. Well, thank you everyone for spending your afternoon with us to go over this really exciting grant opportunity. And like Jen and Kim stated, please message Jen Catajo if you have any questions. And we will, like Kim stated, get this posted on our CROA website as soon as possible. And also feel free to email me directly if you have any questions as well. And just thank you so much for your time, and we look forward to getting your applications. Okay. Thank you so much, everyone. Take care.